Welcome to the Deck Dive. Today, we're cracking open what's really considered a landmark paper in vascular surgery.
Hmm.
We're using the book 50 Landmark Papers Every Vascular and Endovascular Surgeon Should Know as our guide. And while the study we're pulling out today has lessons that go way beyond just surgery.
Exactly. We're getting into the late results of surgery for celiac artery compression syndrome, CECS, or what most people probably call MEL-S nowadays,
Yeah.
median arcuate ligament syndrome.
Right. Mel. It's a condition that, still causes a lot of debate. We don't have all the answers.
Not at all.
And the source we're using for this deep dive is a really key 1985 article. It's from the Journal of Vascular Surgery, Riley and colleagues.
That's the one.
Yeah.
Late results following operative repair for celiac artery compression syndrome. It was like a really early, significant look at how to treat this tricky condition.
So our mission for you listening is pretty straightforward today. We want to understand the key findings from this paper, why it was so influential.
Yeah. What did Riley actually learn about the long-term effects of surgery for symptomatic MALS? And why are we still talking about it, almost 40 years later?
Okay, so let's set the scene. Back in the mid-'80s, say CS or MALS, it was kind of a puzzle, wasn't it?
Oh, definitely. There was this big question mark around how important the physical compression actually was. Like, what did it mean clinically?
Why was it so unclear?
Well, two main reasons, really. First, we didn't have a solid grasp on the pathophysiology, exactly how the compression caused the symptoms people felt.
Okay.
And second, you'd often see this same compression on imaging in people who felt completely fine. No symptoms at all.
So just because you saw the compression didn't mean the person was sick. That makes diagnosis super tricky.
Totally. And that's where this Riley study comes in. Their goal was, okay, let's look at the patients who did have surgery for symptomatic MALS. What happened to them long term?
And crucially, could they figure out who was most likely to get better? Any predictors?
Exactly. That was a key part of it.
So how did they go about it? What was the study design?
It was a non-randomized, single-center retrospective review. So basically, they looked back.
Okay, looking back at records.
Yeah, records from their hospital. 51 patients who had had this surgery for symptomatic CCS. It wasn't like a trial where they assigned treatments randomly, but it gave real-world data.
And the follow-up time was pretty significant, I gather.
It really was. That's one of its strengths. They managed to get follow-up info on 86% of those original 51 patients.
Wow.
And the average follow-up was 9 years. 77% followed for at least 5 years, and almost half, 47%, for over a decade.
That kind of long-term view is pretty rare, especially back then.
Absolutely. Makes the findings carry a lot more weight.
Now, these 51 patients, they didn't all get the exact same operation, right? There were different approaches.
Correct. They grouped the surgeries into sort of 3 main types.
Okay.
First group, 16 patients, they just got celiac axis decompression. So releasing that tight band, the median arcuate ligament.
Just freeing up the artery.
Right. And they also removed some of the nerve tissue nearby, the periarterial neural tissue. The thinking was maybe that contributed to pain too.
Okay, so pressure off the artery, pressure off the nerves. What else?
Second group, 17 patients, got the decompression plus a dilatation. So surgically widening the artery itself a bit.
Okay, addressing the vessel directly.
And the third group, 18 patients, had the most extensive procedure. Decompression plus reconstruction of the artery.
A reconstruction, like how?
Either cutting out the narrow bit and sewing the ends back together, that's primary reanastomosis, or putting in a graft. Could be a vein, another artery, or even, a synthetic dacron tube. Bypassing or replacing the compressed part.
Right, so quite a range. Simple release, release plus widening, or release plus a whole rebuild. So what happened when they looked years later? How are these people doing?
Well, the big picture was overall, 68% of the patients they could follow up were asymptomatic. Their symptoms were gone.
Okay, more than 2/3. But that leaves
32%, almost a third, who were still symptomatic, still having problems.
That's a pretty significant chunk still suffering. Did it matter which type of surgery they had? You said that gets interesting.
It really did. This was a key finding. The outcomes were significantly better if patients had decompression plus some kind of revascularization, either the dilatation or the reconstruction.
How much better?
76% in that combined group were asymptomatic long-term. Compare that to only 53% who just had the decompression alone.
Wow, that's a big difference. So just releasing the ligament often wasn't enough.
That's what it strongly suggested. And, before this paper, a lot of the focus was just on the mechanical squeeze. Riley's work was like early evidence that maybe the blood flow through the artery was really, really important for long-term relief.
Yeah, that makes intuitive sense. If the artery is damaged or narrow from the compression, just taking the pressure off might not fix the flow problem.
Exactly.
Did they look at the arteries themselves later on with imaging?
They did, yeah. They got late follow-up arteriograms, those X-ray pictures of the arteries on 18 patients, and it was pretty telling.
What did they show?
In the asymptomatic patients, 70% had a patent celiac artery, open, good flow.
Okay.
But in the patients who were still symptomatic, 75% had an artery that was still stenosed, narrowed, or even totally blocked.
So a really strong link between an open artery and feeling better.
Seems like it. Maintaining that blood flow looked critical.
Okay, so we have these overall results, the importance of revascularization. But the study also tried to figure out who did well, right? Were there patient factors involved? Let's talk about those predictors.
Yes, they dug into that too. They found a few things linked with good, sustained relief.
Like what?
Patients with classic postprandial pain, pain that reliably came on after eating cupping, they did really well, an 81% cure rate.
Okay, that specific pattern was a good sign.
Very good sign. Also, age between 40 and 60 seemed to be a sweet spot, 77% cure rate there.
Interesting.
And patients who'd lost a fair bit of weight beforehand, 20 pounds or more, they had a 67% chance of being asymptomatic after surgery.
Huh. Any idea why the weight loss mattered?
Well, the thinking often links back to that ischemia idea. You eat, your gut needs more blood. If the artery's tight, can't deliver, you get pain, maybe avoid eating, lose weight. So significant weight loss might be a marker of significant underlying ischemia from the compression.
I see. So that classic story pain after eating, maybe weight loss pointed towards a better surgical outcome. What about the flip side? Factors linked to less success.
They found those too, unfortunately. An atypical pain pattern, maybe pain that came and went, periods of remission.
Yeah.
Only a 43% cure rate, much lower.
Okay.
Also, a history of psychiatric issues or alcohol abuse was associated with poorer outcomes. Only 40% cure rate in those groups. And being older, over 60, also seemed less favorable, 40% cure rate. And losing less than 20 pounds beforehand, only a 53% cure rate.
So it really wasn't just about the anatomy. The patient's whole clinical picture, the pain details, other health factors, they all seem to matter for surgical success.
Definitely.
Now let's bring in that expert commentary perspective. How big a deal was this paper back in '85? What was its impact?
Oh, it was huge. Riley's paper was, as we said, a landmark. It was really the first proper study in the vascular literature that showed, yes, surgery can work for males, and here's some evidence for how it might work best.
By addressing the artery itself, not just the ligament?
Precisely.
Yeah.
That shift, looking beyond just releasing the ligament to focusing on restoring flow, was a major step. And remember, they got these results without the fancy imaging like CT scans we have now, or minimally invasive tools.
Right. Puts that 68% overall success rate and the 76% with revascularization in quite a light.
It does. But the flip side, that 32% failure rate, that's also important.
Why is that?
Because even today, with all our advances, studies still show roughly that kind of failure rate. Maybe a bit better, but MALS remains challenging. Complete symptom relief just isn't guaranteed.
So the expert take is, this study was foundational, but it also highlighted an ongoing challenge.
Exactly. And it reinforces why surgery for MALS then and now is usually seen as a last resort. You try medical management first.
Makes sense. The study also tried to define the ideal patient, right? Based on those factors we discussed.
Yes, it made a real contribution there. Trying to characterize who has MELS and who's likely to benefit from surgery. They were pretty careful for the time, required extensive GI workups, angiograms, looked at psychiatric history.
But it's still hard to pick the right patients.
It absolutely is. That remains maybe the biggest challenge, because we still don't fully, completely understand the why. The exact mechanisms makes the diagnosis tricky sometimes. I remember a case early in my training. Patient had textbook symptoms, pain after eating, weight loss. But their duplex scan, the ultrasound, was normal. Didn't show significant compression with breathing. It just shows, the puzzle this paper first started trying to piece together.
So are there better diagnostic tools now? You mentioned duplex.
Yes, that's become pretty standard in many places. Mesenteric duplex ultrasound with respiratory maneuvers. We watch the artery on screen as you breathe in and out.
And that helps.
We think so. It lets us see the dynamic compression from the ligament when you exhale fully. It helps us be more selective. Generally, if that duplex is normal, even if other scans show some compression, we're hesitant to offer surgery.
Okay, a useful tool. Now, Riley's paper touched on why patients might have pain. the theories back then.
Yeah, they discussed the two main ideas. One, arterial insufficiency. The compression limits blood flow, causes ischemia, especially after meals when the gut needs more blood. That causes pain.
Makes sense. The other idea.
The other was direct compression of the nerves, the celiac ganglion, which sits right near the artery. The ligament squashes the nerves, causing direct, sort of somatic pain.
And Riley's findings seem to lean one way.
They leaned pretty heavily towards the blood flow issue, the ischemic idea. Remember that strong link they found between a patent open artery after surgery and the patient feeling better?
Right.
That really pointed towards restoring flow being key. But it's not totally clear-cut, even now. Well, the abdomen has amazing collateral blood flow, backup routes, especially in younger people without atherosclerosis. So is the ischemia always severe enough? Plus, sometimes people do okay without surgery, even if the celiac artery clots off or dissects. That wouldn't fit perfectly if ischemia was the only cause.
Okay, so still some fuzziness around the exact mechanism. How about the surgery itself? How has that changed since '85?
Big changes. Minimally invasive is much more common now. Laparoscopic robotic surgery to release the ligament.
So smaller incisions, quicker recovery, presumably.
Generally, yeah. Open surgery, like in Riley's study, is less frequent. Interestingly, using stents inside the artery hasn't been a home run.
Where?
They tend to re-narrow over time. Restenosis is a real issue in that spot.
Got it. Has the goal of the surgery changed with these newer techniques?
To some extent. There's often more focus now, with minimally invasive approaches, on really thoroughly dissecting and removing that celiac ganglion nerve tissue.
Ah, targeting the nerve compression theory more directly.
Kind of. And some experts even wonder if the reason the reconstruction group did better in Riley's study wasn't just the blood flow, but maybe because doing that big open reconstruction required a more complete removal of the ganglion tissue, incidentally.
That's fascinating. An unintended side effect, possibly driving the better outcome.
It's a thought. Shows how complex it is.
So wrapping up the expert view, what's the lasting legacy of this Riley paper?
It's still just a cornerstone, the first really detailed characterization of this complicated condition. We're still building on it, still learning, but their careful work, that amazing long-term follow-up, is why it remains so important. It laid the foundation.
Okay, so let's quickly recap our deep dive. The Riley study showed surgery can offer real, lasting relief for MELs, and keeping that celiac artery open seems vital for long-term success.
Yeah, that was a key takeaway.
We also saw that certain things about the patient, their pain pattern, age, weight loss, could hint at who might do best with surgery.
Right, helping with patient selection.
But, as the expert commentary stressed, and as you've said, it's not a magic bullet. Malice is still tough. Diagnosis isn't always simple, treatment is still evolving, and success isn't guaranteed.
Precisely. It remains a challenge.
Which brings us to our final thought for you listening. Given that we're still debating the exact why behind MEL symptoms and surgical outcomes still vary, what else might be going on? Beyond blood flow, beyond the factors Riley identified. What other things could be influencing a patient's long-term journey with this condition?
It really makes you think about how complex these things are.
Definitely. It underscores that medicine is always learning, always evolving. Thanks for joining us for this deep dive.